Hello, I'm going to talk about resuscitative endovascular balloon occlusion of the aorta, known as 𝗷𝗿𝗃, its role and limitations and precautions. As well as working in Leeds Vascular Institute, I also work with the UK military. However, this presentation is my own opinion. I have no financial conflict of interest to declare. 𝗷𝗿𝗃 is the action of inflating a transluminal catheter-mounted balloon device within a discrete aortic segment for a discrete time interval with the intent of facilitating resuscitative efforts for the patient. Chiefly, this is through a degree of proximal control and prioritising the proximal circulation over the distal circulation. This picture shows 𝗷𝗿𝗃 via a percutaneous right femoral sheath. At higher volumes of inflation, the balloon will form a circumferential seal with the aortic wall, sustained through each cardiac cycle. The trauma team will decide whether they intend to use this capability or whether to inflate without full occlusion, so-called partial 𝗷𝗿𝗃. There are many different types of balloon catheters that are in use. This is an example, the 𝗓 catheter. It's the most expensive, but in my view, the most efficient to use device that is commercially available. It uses 7 or 8 French access, does not require guide wire, and a balloon can be positioned with reference to surface anatomy alone. 𝗷𝗿𝗃 is used in trauma for exsanguinating subdiaphragmatic bleeding. You can see here the archetypal injuries and the corresponding balloon positioning. On the left, an exsanguinating liver laceration with a supraceliac balloon inflation, so-called zone 1 𝗷𝗿𝗃, and on the right, an exsanguinating pelvic fracture with an infrarenal balloon inflation, zone 3 𝗷𝗿𝗃. Differentiating these exsanguinating patients from shock mimics during the resuscitative phase is not as easy as it might sound. To help identify such patients, there are the hateful 8 signs. An exsanguinating patient will have most of tachycardia or bradycardia, hypertension, a low or falling end-tidal CO2, altered mentation, clamminess, pallor, hunger, and venous collapse. Penetrating wounds, positive fast, and severe pelvic fractures all increase the index of suspicion of a diagnosis of exsanguinating injury. Clearly, if there is a traumatic cardiac tamponade or life-threatening thoracic bleed, 𝗷𝗿𝗃 is not the initial approach to take, as it is likely to aggravate such pathology. 𝗷𝗿𝗃 requires a well-functioning and resourced major trauma system from the point of wounding. You will appreciate that the target group of patients for 𝗷𝗿𝗃 will need expert team pre-hospital care to arrive at the hospital alive, expert team hemostatic resuscitation, rapid definitive control, and restoration of perfusion. The clock is on as soon as the balloon goes up. There is a range of multinational registry data regarding the use of 𝗷𝗿𝗃 in adult patients. Populations include a wide age range, conducted in diverse, well-resourced major trauma systems. Comparison groups include resuscitative thoracostomy patients, propensity-matched non-thoracostomy patients, and different strategies of 𝗷𝗿𝗃 use. The primary outcome measure is usually survival to leave hospital. This data produced a range of views and justified the UK 𝗷𝗃𝗃 trial. This trial ceased recruiting in April this year on the direction from the Independent Data Monitoring Committee. We are awaiting their findings. The complications and disadvantages of 𝗷𝗃𝗃 will depend on the manner in which it's conducted and the access process. When looking at the literature, these are the 7 𝗷𝗃𝗃 specific points I consider. There is observational study evidence that partial 𝗷𝗃𝗃 has better survival. As Professor Joe DeBose would say, let the visceral organs take a bit of a drink. If you or your team inherit someone with a 𝗷𝗃𝗃 in situ, then it is worth checking that the rationale is appropriate for 𝗷𝗃𝗃 use, that the balloon is appropriately inflated, have an index of suspicion for thrombus around the sheath, and check the balloon is where you are being told it is, and not, for example, in the venous system or in an arterial branch. This last point can be done by checking the device insertion level, blood pressure trace, and potentially some form of imaging. This is a busy table. I show it only to demonstrate that recognising the pitfalls and unsurprisingly allows you to plan and incorporate mitigations. So, in summary, 1. 𝗷𝗃𝗃 is an appropriately safe technique for proximal hemorrhage control and prioritising the proximal circulation. 2. When the balloon goes up, the clock is on. 3. The UK 𝗷𝗃𝗃 trial may answer some of the uncertainty. 4. If using 𝗷𝗃𝗃, let the organs take a bit of a drink. Thanks very much for listening.
We'll also have a next virtual lecture by Tim Stansfield again. Would you put it on, please? It will be
I'm
on...
now going to talk about the case for tranexamic acid, or TXA, in trauma, its role, evidence, and I'll clarify who benefits. My declarations are as before. TXA is a synthetic analogue of the amino acid lysine. It is an antifibrinolytic. It works, with an example shown in this picture, principally by competitive and reversible binding to the lysine sites on the plasminogen complex and preventing plasminogen conformational change to plasmin. Plasmin is a cleaving protease which dissolves the cross-linked fibrin mesh. In normal hemostasis, that property usefully prevents excessive clot propagation. My hospital in Leeds pays the equivalent to about 65 Egyptian pounds for a 1 gram ampule. TXA serves two purposes in trauma. Firstly, as an empirical measure to those patients who are significantly bleeding. A postulated mechanism is that TXA helps sustain the cross-linked fibrin mesh at sites of clot. The first clot is a best clot, and preserving fibrinogen, platelet and coagulation protein levels will intuitively be helpful in those patients with trauma-induced coagulopathy. TXA is therefore part of so-called hemostatic resuscitation. Secondly, to treat established hyperfibrinolysis, which can be diagnosed on thromboelastometry, as you can see on the picture on the right. There is level 1 evidence for TXA use in trauma, principally from the CRASH-2 trial. CRASH-2 was a multinational double-blinded RCT, which randomised about 20,000 adult trauma patients with or thought to be at risk of significant hemorrhage to either placebo or TXA. Well done to Egypt, who randomised 2,000 patients. The UK only managed 150. Significant hemorrhage was defined as bleeding with a systolic blood pressure of less than 90 and or a heart rate greater than 110. Those randomised to TXA received a 1 gram bolus over 10 minutes, followed by a 1 gram infusion in 100 ml of normal saline over 8 hours. Death in hospital within 28 days of injury, the primary outcome, and death from bleeding was significantly reduced by TXA. Overall, 1 life was saved for every 67 patients treated with TXA. These are young people. Average life expectancy in Egypt is about 72 years, and so you might expect to save 650 patient life years for every 1,000 patients treated. It was particularly profound that in those given TXA, death due to bleeding varied so much relative to the time from injury to treatment. TXA administration needed to commence within 3 hours to show benefit. TXA did not reduce the need for blood transfusion. What about those with a relatively isolated head injury? CRASH-3 was also a multinational double-blinded trauma RCT. It recruited about 9,200 patients within 3 hours of injury with no major external bleeding and either GCS 12 or less or CT evidence of intracranial bleeding. It randomised to placebo or TXA. It didn't show any difference. However, on subgroup analysis, those with a GCS greater than 9 did benefit. You need to treat about 1 in 60 of these patients to save 1 life. And again, it is more effective the sooner you use it. So while I think this graphic from the CRASH-3 trialists is a bit misleading, it makes that point. There are also quite a few animal studies on TXA use, retrospective registry type studies, some of which have propensity matching. I think the MATTER study, which exclusively uses data from Bastion Field Hospital in South Afghanistan, is the most interesting of these. They found, as well as TXA conferring a survival advantage, the TXA patients were also less coagulopathic. Give intravenous TXA to all trauma patients with significant bleeding within 3 hours of injury, provided there are no contraindications, which are principally a definitive analogy or a history of thromboembolic disease. There was no difference in the vascular occlusive events of TXA compared to placebo in the CRASH-2 or CRASH-3 trials, So, when subsequently retrospective registry studies identify a higher rate of venous thromboembolism, I think this is due to confounding. All trauma systems and protocols I have seen take a pragmatic line on this. Give TXA as soon as possible based on pre-hospital findings unless there is a clearly known contraindication, in which case don't give it. The pre-hospital IV bolus can be given with pre-filled syringes to ensure the shortest time to receive from the point of injury. So, in summary, TXA is a safe, effective, low-cost, straightforward to administer adjunct for selected trauma patients. Incorporate its use within all trauma system protocols.